is not a lectural session or kichi nahi through our, as you people know that last 3-4 years I have been trying to integrate surgical and physiotherapy skills together. We all know that a well done surgery is useless without not well done physio. So surgery starts inside a surgical theatre, but it is made into a success by good physiotherapy. That is very important. आज जो Sebastian आस्ट्रेलिया जो कनाडा रू आस्टी से actually he is a friend of my friend. हमें मिसिकी लंडन रे थिलु so his colleague was a colleague of mine. तो से आज मते कहला हमें जो फ्लाइट रास्ते हमें कथा होतलो कि केमती से माने डे केयर आर्थोप्लास्टी करचंती सेम डे पेशेंट को घर को छाडुचंती. तो जेबे पता से कथा हेली तो एमती किसी ग्रेड करू नाती. It is just that the rehabilitation procedures are more structured and more defined than ours. And that is some food for thought for all of us कि केमती हमें ओडिशा रो जो ऑर्थोपेडिक रिहैबिलिटेशन अच्छे केमती एक्सप्लेन करवा. आई एम वेरी लकी कि आज बहुत सीनियर फिजियोस अच्छा जो बहुत वर्ष ओडिशा अच्छा मुझे लेक्चर देवा चाहूनी मुझे चाहूँ आम कथा हेबानी सो दैट आप मन में कौन चैलेंजेस आछी व्हेन यू सी पेशेंट्स व्हाट डाउट्स डू फिजियोस हैव व्हाट आर द कॉमन क्वेश्चंस दैट पेशेंट्स आस्क फिजियोस कि हाउ कैन वी इम्प्रूव इज द मोटो ऑफ दिस टॉपिक टुडे. तो आई एम श्योर आम टे डिफिकल्ट क्वेश्चंस थी आम जमा रागिबानी. Please think of the questions so that once we start the program, and thankfully we have Sebastian, who is one of the leading surgeons in the world when it comes to the direct anterior approach for hip replacement.
Which is beneficial. In many post-rehab patients, I find quadriceps strength appear to be 5:5 in manual muscle testing. Okay, and but they still can achieve terminal knee extensions and they also perform very less effective on quadriceps sets or normal edge gait. So my question is, how do you differentiate? It's called, I think, arthrogenic muscle inhibition (AMI). How could you differentiate it, AMI, from the true muscle weakness, and what are the strategies do you find most effective to overcome it?
So whether it is AMI or muscle wasting or whatever the reason you say, that will be there when cut is there in the skin. That means muscle will go for the waist, and patient is already on the rest for a few days, initial few days. Even if you do the isometric quadriceps, whatever you do on the bedside, the amount of the muscle utility as compared to the other leg is always less. So muscle will go for the atrophy. So you need.
So I'm not sure what Dr. Sandeep's protocol is, but actually in Canada what we've come to realize is a lot of the techniques that we're doing for these patients actually, and with the anesthesia protocols, have a lot less pain after surgery than traditionally. And with this, before when people had a lot of pain, we had to give them a lot of pain medication and be quite aggressive with physiotherapy early on. What we've actually come to realize is for the first week or 2 weeks, we call it a quiet knee protocol. We don't actually want them to do too much aggressive exercise. We want them to ambulate and be safe and do gentle range of motion, maybe to 90 degrees. But the idea of beating somebody and making them feel pain and no gain, we've actually stopped this philosophy completely.